Hi, everyone. Welcome to LDI's virtual seminar. I am Rachel Werner, LDI's Executive Director. Thanks for joining us today for today's seminar on racial justice and national drug policy. So without further ado, I want to get started on today's seminar by introducing our guests today. We're joined by a great panel of speakers today. First, we have Michael Botticelli, who was the director of the Office of National Drug Control Policy for the Obama administration, where he led efforts to respond to the opioid epidemic with a balanced public health and safety approach. We're also joined by Cassandra Frederick, who is executive director of the Drug Policy Alliance, a national nonprofit that works to end the war on drugs and build alternatives grounded in science, compassion, health, and human rights. Elena Hansen is a psychiatrist and anthropologist at UCLA with expertise in the racialization of drug policy. At UCLA, she is a professor and chair of the research theme in translational social science and health equity. And today's seminar will be moderated by Eugenia South, who is assistant professor of emergency medicine here at Penn, and she directs Penn's Urban Health Lab. So with that, I will get out of your way, and I'm looking forward to the interesting conversation today. Thanks for joining us.
Excellent. Thank you so much, Rachel. It is an honor to moderate this panel, and I'm so thankful, Rachel, that as a leader of LDI, that you recognize the vital importance of this topic that we're going to talk about today, and that LDI is devoting a seminar to this. Also, thank you to Mavis and Juzanne for coordinating everything behind the scenes that has gone into making this event possible. And finally, Helena, Cassandra, and Michael, thank you for spending your Friday afternoon with us, or morning if you're on the West Coast, and for all the inspirational work that you all do. I'm really excited to have an invigorating conversation. So to start out, I really want to just set the stage for everyone on this topic of racial justice in national drug policy. You know, throughout the 20th century, the prison population in this country was relatively stable and relatively low. That changed in the late 1970s and early 1980s when the prison population exploded exponentially and the era of mass incarceration began. This period of our history, which is still ongoing, is what Michelle Alexander has coined the new Jim Crow. And that is, of course, because Black people are disproportionately impacted by mass incarceration and the police surveillance state that has served to cycle people in and out of prison. Black people make up about 13% of the US population, but 33%, around 33% of the US justice-involved population. Indigenous and Latino communities are also overrepresented, while white and Asian individuals and communities are underrepresented. In the new Jim Crow, Michelle Alexander makes this argument that in the age of colorblindness and race-neutral laws and policies, that mass incarceration has essentially served the same function as the era of legal Jim Crow segregation as a form of social and economic control of Black people and Black communities. And when we think about what fueled mass incarceration, what laws and policies were created that led to both the ballooning of the prison population and the racial disproportionality of who is there, the war on drugs is really front and center. I want to just read a quote from John Ehrlichman, who was counsel and assistant to President Nixon. I first heard this quote in the fantastic documentary 13th, which I highly recommend. And he said this during a 1992 interview referencing the war on drugs. He said, you want to know what this was really all about? Nixon had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and the Blacks with heroin, then criminalizing both heavily, we could disrupt both of those communities. Did we know we were lying about the drugs? Of course we did. And in 2020, last year, approximately 450,000 individuals who are in local, state, and federal prisons and jails are there for drug-related charges. That's about 1 in 5 people in prison. Drug arrests and charges are destabilizing to individuals and whole communities. Really have to understand it as that. They make it hard to get employment. They may disqualify people from public benefits. Even after people are out of prison, they're often on probation or parole for extended periods of time, which is another form of control that has its own set of challenges. And before we get to our first panelist question, I really just want to explicitly name mass incarceration and the war on drugs for what it is, and that is a stark example of structural racism. And so during the next 45 minutes, we're really going to tease that apart, dig into it, and ask and answer some tough questions about what comes next. So Michael, I'd love to start with you. Reflecting on your time with the Office of National Drug Control Policy, how much did the basic policy approach change from the war on drugs in the 1980s and 90s to the federal response to the opioid epidemic in the late 2000s? And in what ways was equity and anti-racism an explicit or not part of that conversation of federal drug policy?
Sure. So first of all, I really want to thank Penn and LDI for hosting this really important conversation and to being with my kind of co-presenters here today. I've had a number of years to kind of reflect back on my time, and and I'll leave it to others to judge the kind of success or failure of kind of our administration in that. But largely what I think we tried to do in the Obama administration, and not just during my time, was to really move away from a war on drugs kind of approach and really focus kind of drug policy as a health-related issue and not as a criminal justice issue. And for folks who are unfamiliar, there are really there are two ways that Congress granted ONDCP with the authority to do that. And one is by setting that administration's particular national drug control strategy, which is a whole of government approach. And it also gave us a particularly unique authority over the budgets of those agencies to be able to make sure that they had allocated resources across those goals. And I think it's really important, while kind of strategy and rhetoric kind of changed, that budget, quite honestly, was slow to follow. It really was the implementation of the Affordable Care Act and its mandate to include substance use disorder treatment as an essential benefit, where we really saw and even tried to approximate parity between kind of what we call demand reduction approaches, public health strategies, and kind of law enforcement demand reduction strategies. So we knew we had a way to go. But I also think there are other ways that we try to do that. Certainly I tried to use both my personal background and the bully pulpit to be able to do that, and was fortunate to have some kind of high profile ways to be able to do that. I also think by the fact that I was from a public health background in recovery, I think helped kind of amplify and reinforce that approach. But I also think, and there are a couple other ways that I think we tried to do that in kind of non-statutory ways. Things like putting out a memo to encourage agencies to change their language. I think a lot of stigma and kind of racist policy and racist thinking is rooted in some of the language that we use, and that's been borne out. And also trying to kind of minimize the impact that criminal records have in terms of people's ability to go on to be kind of fully participating in the community. And lastly, I'll just say this, in preparation for this, I went back and looked through our drug control strategies to see if there was particular mention in terms of equity-based or kind of anti-racist strategy. And there wasn't. Certainly there was an acknowledgement that, kind of policies of, had a disproportionate impact on people of color. But really kind of, unfortunately, it didn't include specific goals and specific strategies that dealt squarely with this issue. And that's regrettable for me, kind of looking back around it. And again, certainly there was an acknowledgement of the disproportionate impact, but there wasn't kind of particular strategies focusing on this important issue.
Thanks so much, Michael. That's really very interesting. Helena, are you with us? Can you hear us? I wanted to ask the next question of you. So the war on drugs really criminalized drug use for Black and Latino communities, while the opioid epidemic has been met with much more of a public health approach to drug use. But as your work has documented, within the opioid epidemic, Black and Latino individuals have actually been further criminalized or just ignored. Can you talk about divergent media portrayals in the 2000s of white non-medical opioid users in contrast to Black and Latino heroin users, and how that and other factors led to racialized public and policy responses within the opioid epidemic that still have an impact today?
Thank you for that very astute question. I'm going to try to be brief and give you a nutshell answer for what is really a decade of research that I discovered well into the research was really about how the opioid crisis came to be seen as white, in contrast to the prior heroin and narcotic quote-unquote epidemics that you mentioned. And my punchline is that the past century of racialized images of who is an addict that you're alluding to, prior to the quote-unquote white opioid crisis, those racialized images have ended up hurting white Americans just as they hurt Americans of color. So in brief, the popular press and politicians have been circulating images of Black, brown, and even Asian people as addicted and dangerous for over 100 years. And you opened up with a quote from Nixon, a Nixon cabinet member about that. So for over 100 years, these racialized images have built political support for prohibitionist criminalizing drug policies. And so this began 100 years ago with anti-Asian images of Chinese opium dens as luring innocent white women into sex slavery in the early 1900s, when the U.S. was trying to limit narcotics imports from China in the wake of the opium wars. And that, to further build support for illegalizing narcotics around that time, narcotics that at the time were freely sold in doctors' offices, pharmacies, and even soda shops. By 1914, papers like the New York Times were reporting that cocaine-crazed Negroes, Black dock workers in the South, were attacking their white supervisors and raping white women. And then a couple decades later, to build support for illegalizing marijuana, by the 1930s, newspapers showing images of Mexican marijuana madness and Mexican workers who were sleeping on the job under the influence of marijuana. So these images led to more and more stringent narcotics laws and enforcement in Black and brown communities, which live with us even today, as you said in the opening comments. Richard Nixon's chief advisor himself talked about how these images justified the war on drugs, really as a form of political repression. So all the while, middle-class white people throughout the past century have enjoyed full access to medical narcotics prescribed by private doctors in such large volumes by the 1940s that by the 1940s and 50s, white Americans were dying from barbiturate overdose rates that rival today's opioid overdose rates. And later, they were dying from benzodiazepines that were marketed like Valium as Suburban's mother little helper. So when the manufacturers of OxyContin and similar extended-release oxycodone products got to work in the 1990s, they tapped into these racialized images that I just mentioned before of illicit and addictable Black and brown people versus legitimate white pain patients with neuroscientists, drug developers, with FDA and DEA regulators, and through targeted ethnic marketing to get their product to an unprecedented huge market of insured primary care patients in suburban and white rural areas with moderate pain like lower back pain. So all of these materials showed white patients and their drug reps for these new opioids referred to quote unquote trustworthy patients in coded language that meant white consumers. And then the geographic targeting of this marketing of the newly patented opioids to suburban and rural white areas, these all reassured regulators and Congress that these opioids were safe, not only because of their expensive patented sustained release capsule technology, but also because they were intended for a safe population, a white one which had long been portrayed as less prone to addiction. So for a long time, we've had these two different tracks of narcotics access, illegal, and which was used to justify racial political suppression through arrest and incarceration, and then legal, a white one used to market dangerous and profitable new drugs to a white middle class through clinics. So what's different about the current moment is that the national response to growing opioid overdose among white Americans and the response to the tenfold increase in opioid prescribing and consumption that the aggressive racially targeted marketing strategies of the manufacturers led to, it was not a popular political response to criminalize those people, white middle class opioid users. That just wouldn't have been tenable, and criminalization of, for example, heroin was never intended for white people, especially the white middle class suburban people that were heavily marketed to and affected by overdose. So heroin, coming as it did in the wake of heroin in really growing white, suburban, and rural opioid markets, driven by drug monitoring laws, tamper-resistant formulations of opioids, and a stranded generation of opioid-dependent people in white neighborhoods. What this did was it put heroin in a really unprecedented position. So the heavily racialized and illegalized heroin all of a sudden could not be responded to with the same racialized drug policies that had been in place to repress Black and Brown Americans. And this surprising new face of addiction that was reported in the media with lots of humanizing stories of college athletes, housewives, school teachers who unwittingly got addicted to pills and ultimately heroin, built support for local decriminalization of heroin and other opioids in white, largely affluent neighborhoods, whose empowered residents collaborate, for example, with local law enforcement and district attorneys to divert people arrested on lower-level drug charges to sentencing and treatment, and in some cases, peer support. So we get Good Samaritan laws protecting people who call 911 in case of an overdose out of this moment of selective racialized decriminalization. We get bipartisan national support for the medicalization of heroin, as well as opioid addiction, by clinically maintaining patients on the opioid buprenorphine. And buprenorphine itself was heavily marketed to a white middle-class market. To this day, 20 years after the legalization of private office buprenorphine for opioid and heroin dependence, white patients with opioid use disorder are 3 to 4 times as likely as Black patients with opioid use disorder to get buprenorphine. And those white patients who get it are most likely to pay out of pocket for very expensive patented medication or with private insurance. So we're talking about a middle class and affluent market for buprenorphine, and therefore a middle class, white, and affluent constituency for selective medicalization of addiction. So none of this disparity was accidental in any way. It was deliberate. The medicalized alternative response to an emerging white heroin problem was crafted to handle this anomaly of racial crossover of heroin, the image of heroin, after a century of narcotic segregation into drug policy that separates illegal Black and brown drugs and drug use from legal white medications. So none of this is an accident. And media coverage and popular representation of the race of drugs and the race of people who use drugs over the past century have led us to this moment.
Ooh, thank you so much for all of that. It's really fascinating to think about. And even going back 100 years, I learned something about how drug use has been racialized. You know, one of the things that's been fascinating to me over this last year plus as a country, as we are having this renewed reckoning with the history of racism in our country, is how we understand our history and how that history is discussed and plays into the creation of policy, as well as the work of advocacy groups. And so I'm curious, both for Michael and Cassandra, how have you seen this history talked about as you're sort of moving forward in this work? How do we think about this history? How do people understand this history and the role that it plays in policy?
I'll start, and then Helena can kind of chime in here. You know, having kind of worked in the field for a kind of very long time, you know, and then kind of seeing the response that we had, as you know, Helena articulated, to kind of nice white kids kind of now getting addicted and having a kind of much more kind of robust kind of health response, you know, to this issue. You know, I think that part of this has been kind of an acknowledgement of then how do we capitalize on kind of that momentum to try to kind of implement particularly kind of services and treatment services that work, not just treatment services, but harm reduction services, recovery support services that actually work for everyone. and really try to use that as an opportunity to kind of implement and write some of those kind of policies that had a specific disproportionate impact. And, you know, we used to have those conversations in the office all the time about how do we capitalize on the fact that people are much more willing to have a humanistic kind of health response to this because it's white folk, and use that as an opportunity to leverage change that lessens some of the disproportionate impact.
Cassandra, what do you think? You want to weigh in?
I think it's been really hard and difficult. I think it is this history that makes it really difficult for communities of color to actually engage in the policy. I think that, you know, in someone who's like worked to build multiracial coalitions, especially on the issue of overdose, I think that you've found a lot of folks saying like, this is exactly what we knew would happen, right? Like we would not see a change unless white people died. And I think there's two things happening. One, there's the historical inaccuracy. White people have always used more drugs than us, right? Like that is historical, but the narrative and the enforcement does not support that history, right? And so there's a lot of unlearning that has to happen when we're doing advocacy. It's also such a illustration of why white supremacy is so damaging, right? Because in advocacy around and policymaking around or the overdose crisis, it has been really difficult because folks who are impacted now are saying, look, you know, what happened in the past is hard and terrible, but we're here now, let's move forward. And the thing is, people are coming with their pain and their trauma, but other communities are coming with historical trauma. And so therefore, you're asking us to come in as if we're in an equitable place, and we're not, right? And ignoring that we have that trauma, people don't see it as an opportunity, right? They see it as more labor, right? And it makes it more difficult for us, right? And then I think, and you know, it also is extremely frustrating because it has made my work more difficult, because when I'm trying to ring the alarm in communities to say, like, do not believe TV, do not believe politicians. We are not saved from the overdose crisis. This is not just happening to them. We know what happened. When white people get a cold, Black people get pneumonia. Like, we know that this is what's going to happen. And literally, when we look at overdose now, we see that it started to level out, and this dramatic increase among communities of color at the same time where we're seeing folks really buckle down on law enforcement, right? When we are seeing drug-induced homicide bills spread across the country, where we're seeing the rhetoric around drug sellers really intensify, where we're seeing the same xenophobic kind of conversations around the Asian folks and fentanyl, Mexicans and bringing heroin, those same rhetorics are coming up. And now it has been calcified because of media, the historical inaccuracies. And it's important to say the overdose crisis, the rhetoric was compassionate. The policies were not, right? It's not as if all the draconian policies had stopped. And so I think some of the stuff that has been hard around the historical inaccuracies, it has made it more difficult for us to actually get to the structural issues that make overdose so devastating. And now we're in a situation which was, you know, overdose in general, I believe is preventable, but the stark rise in Black and Latinx communities was entirely preventable. But because of the way that we decided, we let the rhetoric decide what the strategies were, we let the rhetoric create what the policy solutions are. Things like Good Samaritan laws, helpful. Are they as effective? Laws, you know, like laws that we worked on, right? We were like, call 911. But at the end of the day, the thing that has been important is the role that criminalization has played. Folks were focusing on like, let's get people into drug courts. And the response has always been, let's remove criminalization. That has been the thing that we have been trying to navigate. And also, let's be really clear that the overdose crisis is being exacerbated by structural issues of economic immobility, issues of esteem, the fact that more people of color are coming into positions of power and some white people are losing their minds. And we're seeing that on January 6th. We're also seeing it show up in healthcare. We're seeing it in the way the myth of white displacement, that people of color are taking these spaces and people are like, it is showing up in different ways. So I think it's made it more, I think the history has made it more difficult. The historical inaccuracies have made it difficult because that has been the language that has surrounded and created the movement. So I can be in spaces where people are talking about the opioid settlements and the advocacy around it is white. And the conversation about who needs the money is white communities, right? And it's like if you guys want to do racial justice in marijuana, that's for Black people, fine, you get those. But opioids impacted us the most. And we are the ones that deserve this money. We were the ones that are most hurt by this. And so we're in this moment where people think that the only families that lost people to overdose are white. Because the historical inaccuracies, the stigma, make it hard for us to have families of color to say, like, I lost my kid to overdose, because you don't get that same compassion back as to why your kid struggled to overdose. It is, there's a different level of scrutiny on that familial unit than the white upper middle class suburban family.
Thank you, Cassandra. Really powerful. A lot to unpack there. One of the things that you mentioned that I want to ask you about is about the role that the criminal justice system continues to play in dictating what happens to people who use drugs. You've had a lot of experience working towards the complete decriminalization of drug use and disrupting those links between the criminal legal system, treatment, and overall health. So I'm wondering if you could talk about your experiences in Oregon, resistance that your group has faced, particularly from treatment facilities, and what you sort of think is at the root of that resistance, and tying that back to this historical context that we're trying to operate within.
Thank you for that question. I think that the things that I believe are necessary for us to move forward is for us to really reduce the role of criminalization when it comes to issues of health. And what we have conceded and that people are pushing back on now is that the criminal justice system is an appropriate vector for healthcare. And I think that we see that because, some of the largest treatment facilities, either for mental health or for drugs, are local jails and prisons, right? And that is a failure. That is not like innovation. That is a failure, right? You have people who are incarcerated that could be better served without being in a carceral facility, who are now contained and in cages, and then we're trying to give them the help that they needed on the outside, right? And I think what has happened in this concession is that we have built whole industries around health and the carceral system. I think there's also the questions that we're not asking. Some people believe that we need, the carrot and the stick. What we would offer is that some people get the stick way more than they get the carrot. And because of that, I think it's really important for us to remove the stick, because there isn't a way for us to do that. And treatment facilities in Oregon, some of the things that was really difficult for us was that we had treatment providers who were saying we were getting rid of pathways to treatment because we were removing the criminal justice system. And at the point that we believe that caging someone is a pathway to help is ridiculous to me, right? And to a lot of the people that I work with. And people believing that in order for people to get help, we needed to have them under a coercive setting. And that to me means that we need to have different conversations about how do we make treatment more attractive for people? How do we incentivize people to treatment that doesn't have to do with taking away their liberties and freedom? And you know, when you dig into it, you realize that a lot of treatment facilities, a good majority or a significant portion of the referrals come from the criminal justice, right? And there is this relationship where they're working together, and you know, there are some folks that see the efficiencies in that, but I believe that it is inherently something that is holding us back from building the healthcare that the people who are struggling with drugs actually need.
I'll ask another question for all of the panelists. What would it look like today to really infuse equity and anti-racism into drug policy at the local, state, and federal level? Michael, I thought it was interesting, and thank you for sharing that, you know, in reflecting on your time, that, you know, equity and anti-racism maybe were not, you know, an explicit part of the thinking and formulation of policy. So I'm curious for all of you, what would that look like? Are there successful efforts that you have seen to do this? What are the challenges to really framing all of this around equity and anti-racism? And what are the things that we need to do and talk about to overcome any of those barriers?
So maybe Michael, did you want to hop in?
I'll jump in with a couple that I think are really important. I think it was Cassandra or Helena that talked about changes to the buprenorphine regulations. You know, but one of the things that did come out of the Nixon administration was a tremendous expansion and implementation of methadone, right? So in keeping with those policies, it's no surprise that methadone is probably the most highly regulated medication to ever exist. And you know, it's highly regulated, highly stigmatized. You know, many, including me, have talked about kind of the racial underpinnings of methadone regulations. And I think at the federal level, one of the things that we can really focus on, like if we can do it with buprenorphine, methadone regulations haven't been updated in, I believe, close to 60 years. And I think it's really a time for an overhaul of those regulations, because I do think it can have an immediate impact. I think the second piece that I'll talk about is more widespread criminal records reform issues. We know, and I think we're going to talk about it later, that some of the supports that people need, both in terms of stable housing, employment opportunities, and others, are really significantly negative impacted by long and not evidence-based lengths of time that criminal records stay and follow people. So I think we've seen some successful efforts at the state level to be able to do that. But I think that those are kind of two, I think, examples of things that we can kind of work on and should be able to work on right away that might help with some of these issues.
Yeah, I think those are right on target, and I also think Michael's comments amplify a critique that Cassandra has had of criminalization and medicalization as being our two options, right? She started off with an example, and I think Michael really highlighted that with methadone, of how criminalization and medicalization actually aren't necessarily polar opposites. They're blended together intimately in our system. And depending on your race, you're going to fall on one end of the spectrum or the other. But they are not two separate alternatives, right? And also, I just want to amplify another implicit critique here, which is that, you know, medicalization on its own within a really race and class stratified for-profit healthcare system is not going to cut it. So even if we think about this magical ideal that everyone would be on the right medication, so quote unquote, and get the right clinical care, we can't affect that within our current system, which just reflects the racial and class hierarchies of every other sector of our society. The fact that we are a country that spends the most on healthcare per capita of any country in the world, that gets the worst health outcomes overall of any industrialized country. It reflects all of the systemic barriers to healthcare, all of the for-profit motives that are not driven by public health concerns that lead us to spend a lot of money on tertiary care for people who can afford it, as opposed to basic access to care. And one thing we definitely do a horrible job at in comparison with our peer countries is to combine clinical care with social supports and social services. So we spend half of what, for example, France spends on social benefits per capita. And we often when I say we, I'm talking about, for example, addiction physicians like myself will point to France and say, look, and this is part of a magic bullet ideology that I think is a very false trap for us. Look, in France, they introduced buprenorphine much earlier than us for private doctor prescription, and they have much lower overdose rates than we do. And we overlook the fact that France has universal health care. We have nothing resembling that, right? We overlook the fact that in the midst of an HIV and overdose crisis in the 90s, France introduced buprenorphine not into private doctors' offices, but actually into community-based treatment centers and harm reduction centers that combined medications, buprenorphine initially and increasingly methadone, with other kinds of clinical care, and we know that people who use substances often have a lot of other bodily and psychiatric needs, mental health needs. So they combine it with comprehensive clinical care, but even more importantly, help with housing, employment, social supports. These centers have really heavy input from people who use drugs and who identify as activists. And so they are collaborating with community members. These centers are often located in immigrant neighborhoods, low-income immigrant neighborhoods. And so the focus is really on communities that are hard hit by both overdose and HIV, as opposed to those who can pay, which is the way that our system is set up. So we really, and I'm not saying that France is free of racism. By no means is it free of racism at all. But in this country, if we overlook the role of racism in leading to popular support for our system that limits access to health care, that doesn't provide social safety net or social benefits, a number of authors and researchers have recently highlighted the fact that our lack of social safety net is due to racist attitudes about who would benefit from such social safety nets. Okay, so we're embedded in a racist system, and we have a fragmented and inaccessible healthcare system as a result, and it's lacking in any kind of social wraparound. And I just want to end by folding back to something that Cassandra alluded to. It's the idea of reparations. So the current opioid class action lawsuits really do use a logic of reparation. So these predominantly white suburban and rural residents who were so hard hit early on in the opioid epidemic, and we know that the demographics are changing. We know that Black people have the fastest rising overdose rate in the country right now, and there are several states actually in which they have a higher absolute overdose rate than white Americans. So we know it's changing, right? But the impression that the opioid overdose crisis was a white one is leading to a logic of reparations for white communities. And that's what flows out of the discourse of deaths of despair, the fact that people are overdosing because they are in largely white communities that have been abandoned by manufacturing, mining companies, et cetera. And in that logic, or left out of that logic, are Black and brown people who have long suffered from all kinds of repressive narcotics policies. And so I do think if we're going to take on a logic of reparations, we actually have to look at the history of who has been very much harmed by drug policies, as well as pharmaceutical marketing, and apply that logic in a way that's very conscious of racial justice. So that is exactly what has been missing from that discussion, that discourse in the class action opioid lawsuits, is a racial justice frame. we would have to insert that, and we'd have to look at investing not only in treatment, classical treatment with medications, but actually all of the social structural drivers of overdose and the harms of opioid and narcotics use.
Well, I just want to drop the mic right there, and I think that's, no, just kidding. That was amazing. Thank you for all of that, Helena. Cassandra, did you want to add anything?
I would just say that the drug policy that's going to be most focused on racial equity and get us that is a drug policy that's based in market disruption. Disrupting the markets of the criminalization, disrupting the current healthcare systems, because for us, even before people struggled with using drugs, even if someone doesn't have an identity of being a drug user, the healthcare system doesn't work for a lot of people. And COVID-19 really exposed how fragile our social safety net is for our community, right? And that's before anyone had to ever use drugs. And so I think if we actually want to build a drug policy that's comprehensive and is that focuses on equity, we have to disrupt the current markets. And I think I take some lessons from the HIV/AIDS community, which really worked to, there were like many different camps. There were folks that were like advocating to be outside of the system, and there were folks that were advocating to be inside of the system. We had the Ryan White money, right? And the face of the white kid who like didn't do any of the bad things, wasn't queer, wasn't using drugs, wasn't black, and it's like this white kid who died, and we're all really sad, and that is true, right? And we think about the CDC report a few years ago where it says 1 in 2 black men who have sex with men will contract HIV/AIDS. And to me, I was just like, wait a minute, how is this possible? And it's the same conversation that we're having with a lot of the same elements based on the fact that our system is not set up for everybody. And the HIV/AIDS community taught us that, and they went a particular way in trying to move forward. And we see the gains that were made in New York City, where I'm from. We see the housing and all these different things, but the fact is we still have 89,000 homeless people, right? And you have these conversations where people are like, well, maybe I should have this so I can get that. Like, we don't want people to have to be in really chaotic life situations in order to get help. So it means that, to me, if I'm taking a lesson from the generators of our movement, right? Because it was HIV/AIDS activists who really laid the foundation for the harm reduction movement in the US. If I'm taking lessons from them, then our policies have to be market disruption and creating markets that use us, because we can't shove drug users in the healthcare system that we have right now. We have to create another healthcare system that centers marginalized communities and then build from the ground up. And that's why it's really exciting in this moment where people are talking about abolition in conversation to the criminal justice system. You have public health folks talking about the abolition of the current medical system as we have it.
Yeah, let me just add, because I think it's important, and particularly to Helena's conversation and Cassandra's piece here, if we're talking about disruption within the healthcare system, I think we've got to talk about dismantling a fee-for-service based system that rewards for things and not for outcomes. And, after I left ONDCP, I worked for Boston Medical Center, which is the largest safety net institution in New England, served a significant portion of people of color. And Massachusetts started moving away toward fee-for-service and more on outcomes-based accountable care. And what we were able to do as an institution then is to focus on all of those structural issues that we knew were contributing to our patients' poor health. right? So things like housing opportunities, access to food, educational opportunities. So, I think it's worth explicitly mentioning that we've got to change the payment of our healthcare system away from fee-for-service and really focus on those outcomes-based issues. And again, I think it was, Cassandra talked about and Helena talked about, how do we infuse those payments with a sense of social justice and looking at equity-related issues. But it's not working, and it's particularly not working for our disenfranchised communities who don't have access, who never had access to a lot of those supports that contributed to their bad health.
I quite agree with that, and I want to come back to Cassandra's holding up of the AIDS activist moment, because even though, yes, I see a lot of failures in this day and age, I also see some real potential lessons, even though, for example, the harm reduction movement that came out of AIDS activism, even though essentially it was politically defeated in a lot of parts of our country. I mean, many modes of harm reduction are illegal in over 50 states, like syringe exchange. Supervised injection facilities illegal in almost all states. So it was politically defeated, but why was it such a threat? Well, it was a different way of approaching health. It was one that was led, for the most part, by people directly affected in communities directly affected. Harm reduction organizations continue to be led by and employ a large number of people who use drugs, and also people who are Black, brown, low income from the affected communities. So it's a very different ethos of grassroots, bottom-up leadership. And harm reduction never was confined to just the public health promoting act, top-down act of giving out safe equipment or anything like. It's actually a social movement, re-envisioning the way that society is put together and envisioning that people would be in control of their own health care. And so I think that ethos we really do need in the healthcare system. So another lesson that I like to take from AIDS activism, you're so right about Ryan White as the cute white straight boy, right? But the Ryan White Care Act that came out of that provided for community control of funding from the federal level. And that community control required people directly affected, HIV positive, taking care of HIV positive loved ones, to serve in decision-making roles. And so I think that's a model that we need to import in the rest of healthcare, not just addiction medicine, but beyond. Diabetes, hypertension, asthma, all these things are concentrated as syndemic chronic conditions among poor Black and brown. And those are the very people who aren't in control of their own healthcare. So I think that we can also learn from that moment.
And I want to be really clear. Like, I think there's things that we have to learn from the HIV/AIDS activism, like in things that they did really well. Like, we're still using a lot of their strategies. I mean, like, we're just using the ACT UP playbook over and over again. And then there's the stuff that it shows the limits. And so I think with the community control, I'm like, yeah, but it's still in that system, right? And so I'm like, what is it like? To me, I'm like, we have to really do the spirit of harm reduction, which is build the alternative system that everyone benefits from, as opposed to trying to convince trying to get the system to acquiesce to our presence, because what is happening is that they're not going to. And so it's like two different things where I think the biggest lesson I'm learning is like, we can't do it here. Like, because even when we get the most that we can get, it's still going to be stratified.
So
I think it's worth mentioning, and I've felt this for a very long time, is, and I know we wanted to talk a little bit about the role of kind of advocacy, but, part of the challenge that we have had in the addiction community writ large, in the field, has been a very kind of, even though it's come a long way, a very kind of fractured, disorganized, not necessarily strategic. And Cassandra, I'm not talking about individual organizations. I'm talking about kind of coalition work that moves this forward, right? Because that's what really happens. And my experience has been that individual organizations have their own thing that they want to advocate for, rather than coming together with a larger agenda in terms of really making change. And I think that has to happen. I think, it's always, I used to talk about the internal external strategy, that if you're inside government, you can only move so far, but it's really the advocacy on the external side that allows you to keep moving the needle forward, right? It's people pushing from the outside gives you cover on the inside to be able to move it. And I will tell you, it's always been challenging when you have kind of advocacy that focuses on their one individual thing versus coming together with a collective agenda. So I think that's, I think it's worth mentioning. And again, I think I've seen it grow over time. The last thing I'll say is absolutely right. Ryan White institutionalized the role of consumers and consumer participation in decision-making authority at every level. And I think it's a really concrete thing we can do at the federal, state, and local level into institutionalizing consumer participation in everything we do, right? So whether that's at the federal level, at the state level, at the local level, and making sure that consumers have an institutionalized role in the work that you're doing.
Thank you all. So we only have time for maybe one quick, short last question. Ann Wilson, one of the attendees, said, how do you build an alternative system? And so I'm wondering if each of you can take 30 to 60 seconds and, what is the first step that you would say that we all need to do, whether it's from an activist standpoint, a policy maker standpoint, or a research standpoint, to start to actually build that alternative system? 30 seconds.
Decriminalization. I think decriminalization is a strategy for multiple issues, be it healthcare, be it communities, be it sex work, be it drugs. I think that is a strategy. I think it is an underlying condition of the way that we can get to a new system is if we remove criminalization, surveillance, punishment, and the idea that coercion is necessary for us to move anything forward.
Thanks, Cassandra. Michael or Helena?
Maybe I'll pick up on Michael's note that rather than operating from different disease states, like asthma has its lobby, diabetes has its lobby, addiction, if we have what's been implicit throughout all of our comments, a structural perspective, so that we understand the fundamental causes of these outcomes that all have a common root.
Yeah.
So we're addressing these structural roots. And it also, how do we address it? It depends on where you are. So speaking of insider, outsider, as a physician, I've been doing a lot of work with my colleagues to retrain our academic medical centers and our practices around addressing structural drivers of health outcomes. So what can, for example, physicians, other practitioners do to collaborate with community organizations like harm reduction organizations? And by the way, in AIDS activism, forward-thinking clinical practitioners and collaborators were important elements. Nurses were behind the Vancouver harm reduction movement that has led us to laws in Canada that have been a beacon for the rest of us on safe injection, syringe exchange. So clinical practitioners can collaborate with community organizations and amplify and support what they do. They can work with housing agencies. They can work with schools. They can work with employers. And they can also work with policymakers. And I'm really glad that Michael was able to give his perspective as somebody who's inside policy. We as clinical practitioners have been very silent in the public policy arena, and that has to stop. And I have optimism about the young up and coming generations of clinical practitioners who are coming into medical school, nursing school, other trainings with a background in social medicine, structural drivers of health inequalities. And they are far ahead of their faculty in acting on those. And so I think it's up to us now to try to formulate that into something, an approach that we can use to address structural drivers.
Let me just add two quick things. One is, and I know we didn't get a chance to talk about it today, but what does our research agenda look like around this issue, particularly because I think it's really important that we have models. Like, I'm anxious to see what happens in Oregon, right? As an opportunity to think of how we go forward. But are there other models that we need to look at? The second thing that I'll mention before we go is, like, it's no secret that we look the way that we do in terms of our categorical funding, because that's how we pay for things. And that I'm not including just healthcare. I'm talking about federal funding streams as well. And I think we've got to look at opportunities for, however you want to call it, braided or blended funding to get at these root cause issues, right? Because if you're an administrator of a federal grant, you can't use the money in those kinds of ways. And I think it would behoove, and I think some of them are on the call today, some of my former federal friends, to work with their colleagues in other health arenas to look at developing kind of pilot grants that get at some of these kind of structural and social determinant issues, because you can only do things that are allowed through kind of funding opportunities. And I think I think the federal government can do a lot to kind of experiment and change, and to give folks at the state and local level the flexibility to implement programs that are more kind of consumer centric.
Excellent. Thank you so much. One thing we didn't get to talk about, but that was a theme throughout, was money, and the role that money and decisions about how money is spent, who gets to make those decisions, really has impacted all of this. And so maybe that'll be the topic for another conversation. But Michael, Cassandra, Helena, thank you so much. This was a fantastic conversation. We could have kept going for a long time. I will turn this back over to Rachel to wrap up. Thank you all so much.
Thank you.
Thank you all so much again for joining us. It was a really powerful and important conversation. I'm so glad that you were able to make it today to have that conversation with us. And also thank you to Gina for moderating today's event, and also being the driving force behind getting this group together and having this conversation. Thank you everyone in the audience for attending. We hope that you'll join us next week. We have a late-breaking seminar coming up here at LDI on achieving global vaccine equity for COVID-19. And we hope to see you there. Thanks, everyone.